Ms. Engy Hamid. She will join us virtually. Ms. Hamid is a medical epidemiologist and a clinical pharmacist. She has been working in the field of antimicrobial resistance and antimicrobial stewardship for more than a decade. Ms. Hamid joined the World Health Organization and the Eastern Mediterranean region 4 years ago, where she has been responsible for supporting the countries to establish national programs of antimicrobial stewardship. Ms. Hamid.
Okay, so good afternoon, everyone. Please first let me introduce myself. I'm Engy Hamid, a medical epidemiologist with clinical pharmacy background. I work as a consultant for the World Health Organization at EMRO, the Eastern Mediterranean region, at the IPCMR unit. I have the pleasure to be with you today, even if this is virtually, because unfortunately I couldn't be physically with you, but I'm really honored with the invitation, and I hope that you will find the presentation useful and helpful to you. So my topic will be, I will talk about the antimicrobial stewardship programs and whether it is beneficial for the countries, especially for low and middle income countries, like most of our region here. So please let me start. So as you all know, antibiotics, they are the cornerstone of the health system. And without antibiotics, many complicated health services and intervention wouldn't be possible without it. For example, like, the hip replacement surgeries, cancer treatment, organ transplants, all of these would be impossible without the presence of the antibiotics and the presence of effective antibiotics, not any antibiotic. So the more that we use antibiotics, the more that we lose them, unfortunately. And of course, this is due to the development of resistance. As you can see here in the first graph at the left, these are the factors that contribute to the development of the antimicrobial resistance. And these are many factors: environmental contamination, healthcare transmission. But as you will see that the highest contribution is from the human and the animal antimicrobial use, or if we can call it misuse or the overuse, and also that the healthcare transmission also it contributes with a significant amount. The graph to the right, you will see that this is to correlate the use of the antimicrobial use with the development and of antimicrobial resistance. And as you can see that the more that we use antimicrobials defined as daily defined doses, the more the antimicrobial resistance will develop. Okay. This is data from the Eastern Mediterranean region, the EMRO, and this data is extracted from the GLASS report. So these are publicly available data, and this is for the 22 countries in the EMRO region collectively. As you can see that unfortunately in our region, we have high resistance rate, especially for the highest one, the red line is for the Cyanobacter resistance against carbapenem, followed by the resistance of Klebsiella to third generation Sphaerosporin, and the third resistance highest proportion is for the Escherichia coli resistance to third generation Sphaerosporins. And not only that we have high resistance in our region, but unfortunately also we are seeing or we are witnessing an increasing trend for some of the resistant profiles. For example, such as the methicillin resistant Staphylococcus aureus, where you can find it that in 2017, it was about 40%, but at 2019, the resistance is increasing to about 45%. Again, this is data from our region, the EMRO extracted from the GLASS, but here we are trying to compare the countries, because as you know, for among 22 countries, of course, there are variation and the resistance will differ from one country to another. So as you can see here, this is the third generation Sphaerosporin resistance E. coli among blood isolates. And this is like a proxy measure for the bloodstream infections caused by this resistant pathogen. As you will see here that the highest countries or the highest resistance was observed in Egypt and Iran and Pakistan, while the lowest resistance was observed in Tunisia. Also, again, although that in some countries such as the Saudi Arabia, the resistance rates are not so high, but again, we can see an increasing trend of resistance in Saudi Arabia and in Lebanon, which is an alarm that we have to be taken into consideration. Okay. Now that we have talked about the AMR burden in our region, what's its causes, what's its impact? I'm sure that most of you are familiar with the grant paper that was published this year in the Lancet in January 2022, and it highlights the burden of the AMR and the mortality associated with it. And as you can see that in 2019, that the mortality attributable to AMR, it even exceeded those caused by the HIV, AIDS, the cancer, and malaria, causing 1,270,000 deaths. The most affected population with AMR was unfortunately among children under 5, where you can see that 1 in 5 people who died due to AMR were children. So now that we have seen that the AMR hits the children hardly, what about the antimicrobial use in this population? This is data from Pakistan in a point prevalence survey on antimicrobial use in 14 hospitals that was conducted in 2020. And here you can see the prevalence of the antimicrobial use by the ward type. You will see that the highest prevalence of antimicrobial use was observed in pediatric or neonatal wards, where you can find that the pediatric medical, 91% of the patients or the children admitted to this ward, they received antimicrobials. The neonatal intensive care unit, almost 96%. The neonatal medical ward is almost 99, or almost all of the neonates admitted to this ward, they all received antibiotics. Again, this is another paper from Pakistan that also highlighted the use of the antimicrobial in children. And this paper, the results within this paper were in line with the PPS that was conducted earlier in 2020, where you will find that almost all, about 97% of the hospitalized children, they were prescribed antibiotics with an average 2.6 antibiotics per patient. Okay. So what is the impact of the antimicrobial overuse in neonates? And this is aside from the AMR. Literature or studies, they have found that the prolonged use of broad spectrum antimicrobials in neonates, it increases the risk of the candida colonization and invasive infection, such as the necrotizing enterocolitis and late onset neonatal sepsis, and of course, death. Also, literature suggests that long-term effects of the overuse of antimicrobials during the neonatal period, through their effect on the, it has an effect on the intestinal microbiome, including the development of atopic diseases. So, how to combat or to reverse this burden of the AMR? We have this powerful tool, the antimicrobial stewardships. What is antimicrobial stewardship? There are a lot of definitions for the AMS or the antimicrobial stewardship programs, but I usually, this is one of my preferred definitions, because it has the elements within it of any effective or sustainable stewardship program. So antimicrobial stewardships are coordinated interventions designed to improve and measure the appropriate use of antibiotics by promoting the selection of the optimal drug regimen, including the dosing, duration, and the route of administration. So any antimicrobial stewardship program, it has to monitor all these elements. The type of the antibiotics is those, it's the frequency and the route of administration. And not only to monitor, but to measure. You cannot have a successful antimicrobial stewardship program without having measures and indicators to follow up to see the progress of the program. So, what are the benefits of antimicrobial stewardship programs? Okay, literature has a lot of assessments for the AMS, but one of, you can summarize it in the benefits. We can summarize it in there's major reductions in the use of key agents, such as quinolones, cephalosporins. In our region, we can focus on carbapenems since we are witnessing increased use of carbapenems. So once we, of course, reduce the use of major antibiotics, of course, it will be correlated with the reduction in the AMR rates. Also, the AMS programs, they can reduce certain infections caused, of course, by resistant pathogens such as the Clostridium difficile, MRSA, vancomycin resistance Enterocoli, and multi-drug resistant gram negatives. And of course, since the infections are caused by resistant pathogens are reduced, of course, this will be associated by reductions in mortality. Okay. So most of this literature is done in the developed countries, so or in high income countries. So does the AMS programs really work in low middle income countries? And I tried to pick up some examples from countries, low middle income countries, to see the real effect of the AMS programs and whether they are effective or not. So this is one study from India that shows that the mean monthly cost for restricted drugs and restricted drugs here, it could be quinolones, cephalosporin, carbapenems, as we mentioned, it dropped by 14.4% in the post-implementation phase. Of course, the AMS, it can reduce, not all, of course, it is reflected on the daily defined dose, the reduction, and hence it will be reflected on the cost of the drugs. Okay, so is really AMS programs worth the effort? Should countries really engage in AMS? And the answer is yes, because again, antibiotics, they are precious, limited resources. AMS can address the excess use of antibiotics, as we've mentioned, and at the same time, it can address and improve the access to antibiotics, because not all the countries in the world have this excess use. Some countries, they suffer from access to certain antibiotics. So stewardship also work on improving or in having access to these antibiotics needed. The AMS promotes education and training of healthcare workers on infections. And this is actually, as we're going to see later, that education and training, this is a core element of any stewardship program. AMS, of course, it prolongs the lifetime of existence of antibiotics by remaining effective. And as a result, that AMS will reduce the development of antimicrobial resistance. And of course, it will improve the quality of healthcare and reduces the healthcare spending. So antimicrobial stewardship, okay, cannot act alone, okay, in order to improve the patient's safety or to improve the healthcare system. It is an interdisciplinary that should work together with the IPC, the infection prevention control, and the diagnostics. There's an interplay between these three disciplines, and it is vital for the health systems strengthening. And with the COVID, this is one of the advantages of the COVID, that it provided an entry point to strengthen all these three disciplines during the post-pandemic era. Okay, and as an evidence for the interplay between the AMS, the IPC, is usually we give an example for the prevention of the surgical site infections. The stewardship component was focused on the antimicrobial surgical prophylaxis use before the surgery, during the operation, and after the operation. But again, only improving the use of the antimicrobials for surgical prophylaxis by itself will not reduce the SSI rates. There has to be a bundle or packages of other activities that will work together to reduce the rates of the SSI. And of course, these care bundles, they are usually to improve the intraoperative techniques, the contamination, the environmental cleaning. So these activities, they all have to work together. Antimicrobial stewardship programs, they are everyone's business. It is not only focused on in the hospitals, it's not only the pharmacist work, it is everyone's, because the stewardship, it's stewardship programs, it starts from the research and development up till to providing the appropriate use by end user, by the patient. So the stewardship, it can affect on, on updating or developing the essential medicine list and ensuring that the country has the access to the right or to the needed antibiotics, the procurement and supply, the distribution, to have regular distribution or with no shortage in drugs. All of this chain, okay, all of these are considered parts of the stewardship programs. Okay, there are a lot of entry points for the stewardship, and usually this is like a common question: from where to start or from where to have a national program for stewardship. Is it on the hospital level? Is it on the national level? And the answer is simple. There's multiple entry points. If the national level is not ready yet, but the hospitals, they have somehow the capacities to have some activities of the stewardship, you can start with the hospital and then to have this bottom-up approach, or the vice versa. But at the end, okay, there is no fixed approach to have to establish a national AMS programs, because there at the end there are multiple entry points. The WHO has developed a toolkit for the establishment of national AMS programs in low-middle-income countries. And the toolkit has highlighted that in order to have an effective and sustainable AMS program in any country, the AMS program should have 4 core elements. These core elements are national plan and strategies, and this will include what is the governance structure, who will be responsible, the terms of reference for the governing structure, what is the strategies, what will be the strategy, what is the national action plan for the antimicrobial stewardship. The second core element is the regulation and the guidelines, to develop treatment guidelines for common infections such as bloodstream infections, pneumonia, to have regulation to prevent the access to antibiotic without medical prescriptions, and so on. The third core element is the awareness, education, and training, and this includes the healthcare personnel, and not only the healthcare personnel, but also the patient, the community, because by including or involving the community, the literature has found that they have a powerful effect on reducing the overuse of antimicrobial use, and hence reducing the rates of antimicrobial resistance. And the fourth core element is supporting technologies and data, because again, if you remember from the definition of the AMS program, you have to monitor, you have to measure the indicators for the AMS programs to know where the program is going, what is the progress of the AMS program. So, okay. These were the core elements for the AMS program. How to implement it on the national level, how to establish an AMS program on a national level. First, there should be a situational analysis. We should know what are the strength, the weakness, and the gaps of any health care system in a country. And within the WHO toolkit, there is this very useful checklist that you can use for evaluating the current context in your country. And as you will see, the checklist, it has categorized the questions into several categories, including, is there a leadership commitment in the country? Leadership commitment in the countries, the competences, are there competences, whether on the national level or the hospital levels? Are there any supporting technologies that the country can use to have this AMS programs? Are there any existing surveillances, whether antimicrobial resistance surveillance, antimicrobial use, antimicrobial consumption, any data to guide the planning for the AMS program? And this is an example for how you can develop your SWOT analysis to have the strengths, weakness, opportunities, and threats. And from here, it will be clear what resources that you already have and what sources you will have to acquire or you will have to procure through the process of the development of the AMS program. The second step is to identify the human resources. Who will be responsible for this national AMS program at the national level? What will be their terms of reference? What are they going to do? What capacities they should have? And usually the WHO recommends to have what we call the technical working group for AMS at the national level. And this is a multidisciplinary group that could include infectious disease consultants, physicians, clinical pharmacists, microbiologists, of course, members of the IPC teams, members from the procurement and for the supply chain. And it will differ the members of the AMS technical working group. It will differ from one country to another according to the needs. But again, it should be multidisciplinary, as we have seen that the stewardship programs, they have multiple entry points, and it can be not only in hospitals, but again, you can have it in the community. So once this technical working group is developed, then there should be terms of reference to know who will be responsible for what. And this regulates the work or the vision of this technical working group. This is on the national level. At the hospital level, the WHO recommends to have AMS committee in each hospital, and the AMS committee to be headed by one of the senior officials at the hospitals, and of course, again, to be multidisciplinary, to have a PC team, a clinical pharmacist, senior physicians, surgeons, microbiologists, to have this variety of healthcare staff. Okay. The third and very important point is once that we have done our situation analysis, we know what's our strength, what's our weakness. We now have the human resources, the group that will be responsible for planning and overseeing of the AMS activities. So now, what actions do this group have to do? What activities this group will select or choose to implement in the country? This will depend on the actual data of the AMR and the AMC or antimicrobial use data that already exists in the country. This will guide how the activities will go for the upcoming couple of years. So the WHO, we usually recommends not only to depend on the AMR data, but again, there should be data on the antimicrobial consumption and a patient level data on the antimicrobial use. As you can see here in this slide, the graph on the right, this is data, AMR data that the country can have or can develop, generate. If you have an AMR surveillance, you can know what are the resistant proportions and compare it by the origin of infection, whether it was hospital or community. This will differ, how to target, which infections to target, where to target it in the hospital, in the community. And again, if the countries need to develop a treatment guidelines, of course, this the choice or the selection of the antimicrobials will differ whether according to the origin of the infection. Okay, a very useful tool, for the country to use to monitor the antimicrobial use or consumption is the AWARE classification. And the AWARE classification, this is WHO classification that has categorized antimicrobials into 3 categories that are access group, watch group, and the reserve group. The access group, this usually contains the antimicrobials with the least potential to develop antimicrobial resistance. And members or agents of the access groups, they are usually the first line choices for the treatment of infections. The watch group, okay, these are antimicrobials with much broader spectrum, and they usually act like the second choice, second line for the treatment of certain infections, and they have to be used in cautious and, of course, depending on culture results. And then we have the third group, the reserve, and this groups, of course, from the name as it implies, these are the groups that need to be reserved, such as the colistin. These are the last the last available antibiotics that work against very resistant pathogens. So WHO has indicated a threshold for the countries that countries should 60% of the country use should be from the access group. This is a target. This is the country that the country should aim to. As you can see in the graph to the right, this is antimicrobial use of one of the countries. And you can see here that 61% of the use was from the watch group. Okay, of course, as a country, and I have this data, one of the actions to be targeted or to be planned by the AMS working group is to shift this percentage, to have the 60% from the access group, and of course to lower the watch group. Okay, now that we have, we have the AMR and the AMS, and the antimicrobial use and consumption data. Okay, so the AMS technical group have to identify what are the AMS actions that are needed. If a country, if the antimicrobial consumption or use of a country is 60% from the watch group, what are the AMS actions that needs to target this? So there are many AMS actions. We have basic, very basic ones, and we have advanced ones. The basic ones, they usually to identify which patients should need antibiotic therapy. And of course, this would depend on the culture results. You can have, of course, to develop antibiograms for the hospital, or to have a national antibiogram. Treatment guidelines that the physicians can use and abide to, and treatment guidelines, to have the first line treatment from the access group. And you can choose whatever AMS actions that are convenient to the country according to the already existing capacities and the data that is available on the AMR and the antimicrobial consumption or use. The fifth step, again, it is the education and training. And again, the education and training, it can target the healthcare personnel in the hospital, it can target the community, it can target the patients, it can target any sector that can have a role in the AMS programs. And the education and training, it can be done in several ways. It can be done to have on-job training, to have training curriculums that are developed by the academia that are delivered to the undergraduate students. You can have a professional organization to be hired or procured to provide this training to the healthcare staff. It can be e-learning. There are a lot of resources for the education and training. And at the WHO Academy site, you will find several courses for the EMS that are very helpful if you want to include it in your education and training curriculum. The sixth step is to develop a timeline action plan, or what we for the AMS. And of course, this will depend again on the SWOT analysis, what activities are needed, and the action plan, it has to identify the exact activity that will be done, who will be responsible for this activity, the timeline allocated for this activity, and of course, budget. The cost budget is very important to be included from the beginning, because we have seen several countries that have developed timeline action plan, but with no budget, and during the real implementation, they face this challenge in how to procure the resources. So we usually recommend, if it is feasible, to include the budget from the beginning. It will guarantee a successful timeline action plan. And lastly, but not least, is to develop indicators or measures for assessing the AMS program. You have to set an indicator for the timeline action plan that you have developed. If you are going to target that the country should have at least 60% of its antimicrobial use from the access group, this is an indicator. If you can have an indicator to include all or 80% of surgical patients will have antimicrobial surgical prophylaxis from the first group, cephalosporin. This is an indicator. you should always develop an indicators that are smart, realistic, and that are related, or of course they are in context with the action plan and activities that you have selected. That was all for my presentation for today. I hope that you find it useful. I will try to be with you alive during the session for any questions or any comments from your side. Thank you again, and it was a pleasure to be with you today. Thank you.